Okay, so I've seen how this is done. If you work for the government, you have to give a disclaimer. So I work for the UK Health Security Agency, but I'm doing this one with my ICNIRP hat on. So you might then ask, who's ICNIRP? So ICNIRP is the International Commission on Non-Ionising Radiation Protection.
Can everybody hear him?
No.
Sorry.
Okay.
Sorry, can't. Still. Is that okay, yeah. Right, now I can dance about as much as I like. So, International Commission on Non-Ionising Radiation Protection. The Commission is independent. We jealously guard our independence. So we do not accept any funding from anything remotely associated with industry or commerce. Members themselves cannot be affiliated with commercial enterprises. We'll have to declare our interest annually, and indeed, we're not even allowed to get a significant proportion of funding for research or anything like that from industry. The Commission is, or aims to be, broadly multidisciplinary, so expertise in lots of areas, and we're a registered not-for-profit organisation. What we can and can't do is specified in our charter. So we are required to advance non-ionising radiation protection for the benefit of people and the environment. We are supposed to provide guidance and recommendations on protection from non-ionising radiation exposure, but we're not to address things like product standards. There are standards organisations to do that. Compliance testing, nothing to do with us. Interference in medical devices, and a particularly difficult and thorny issue, that of the ICNIRP certificate, which is something specific to the UK and specific to the UK planning system. Every time a mobile phone operator puts up a base station, they have to issue an ICNIRP certificate, and it has nothing whatsoever to do with ICNIRP. But they've stolen the name, and we get such grief over it, you wouldn't believe it. We have lots of international relationships, so we are formally recognised as a collaborating non-governmental organisation by the World Health Organization and the International Labour Organization. But we also have formal relationships with lots of other bodies, so particularly of relevance here, people like the International Commission on Occupational Health, the European Commission, and standards bodies such as the IEC and the CIE. So lots of formal relationships. We'll maybe touch back on those in a minute or two. In terms of structure, we've got the Commission itself, and there's a board which does the management stuff, and we're supported by a scientific secretariat, and more importantly, we're supported by a scientific expert group. So these are external scientific experts who are not members of the Commission, but who have particular expertise, and membership of the scientific expert group changes depending on the work programme that we have ongoing. But we rely quite heavily on these experts. And in terms of the work that we do that through project groups. And the project groups are composed of members of the Commission and members of the scientific expert group, and are always chaired by a member of the Commission. The Commission itself consists of, and this is all quite carefully laid down in the statutes, consists of a chair, a vice chair, and up to 12 members. And commissions serve a 4-year term, so what I mentioned in a minute, we're entering a transition period. 4-year terms, each member may serve up to 3 terms, but members are selected on the basis of their expertise in the area, so they don't represent a particular national interest, and they don't represent a particular parent institution. So they are selected on the basis of an independent knowledge of the subject. We try, as far as possible, to keep the composition broadly balanced in terms of geography and gender. It's not always that easy. And of course, because we're a not-for-profit, all the work is voluntary. So I mentioned the period of transition. The current commission comes to the end of its term in a few weeks' time, in July. And that is the current commission, although a couple of members have already retired because they realised that there were going to be a lot of retirements. They wanted to make sure their place in retirement was safe. So we have a new commission that will take over. And There are only 5 continuing members of the old commission who will be on the new commission. So Aki moves into the position as chair, Ken moves into the position of vice chair, and then Anka, Gunhild and myself are the other 3 remaining members. Everybody else is new, and because there were so many new members, we actually decided that we wouldn't go for the full 12 ordinary members this time. We restricted it to 10 to try and retain some continuity. What do we do? Well, the main thing that we do, and the thing most people know us for, is the guidelines up in the top centre there. But actually we do quite a lot of other stuff as well. So we can issue statements on particular things and notes, fact sheets, and we can carry out reviews and run workshops and stuff like that. But the main product is undoubtedly the guidelines. And we have quite a few guidelines in hand at the moment. So for electromagnetic fields, which fall within non-ionising radiation, we have guidelines on static magnetic fields, which were published in 2009. Guidelines on low-frequency fields up to 100 kilohertz, published in 2010. We have guidelines on induced electric fields from movement, strong static magnetic fields, published in 2014. And we have radio frequency guidelines, published in 2020. So that was our most recent big offering. For optical radiations, we have UV guidelines. I'll talk more about those in a minute, but the most recent set were published in 2004. And we have guidelines on visible and infrared radiation, published in 2013, and guidelines on laser radiation, also published in 2013. And also within our remit falls ultrasound. Now, ultrasound is a slightly tricky situation. So the current guidelines were actually issued by our predecessor, the International Non-Ionising Radiation Committee of IRPA, International Radiation Protection Association, and that was back in 1984, so basically 40 years ago. We actually published a statement a month or 2 ago saying we've reviewed all of the evidence on ultrasound, and actually we've concluded that nothing's moved on and not worth trying to repeat or renew the guidelines. So nothing's changed, the 84 guidelines are still the best we can do. Rather sad, but there you are. Status of our guidelines. Well, they're not binding. Nobody has to do what we say. But they are frequently adopted and used by national and international standards bodies. I've mentioned that we have formal relationships with these bodies. Nothing makes those standards bodies use the guidelines that we publish, but they choose to because they are the international guidelines and because they have formal relationships with us. So in terms of optical radiation safety, IEC Technical Committee 76 uses the ICNIRP guidelines, and the Lighting Committee, Technical Committee 34, also refers to them. They may also be adopted by national and international lawmakers. So, for example, within the European Union, European Directive 2006/25/EC on artificial optical radiation was based on ICNIRP guidelines. In fact, a whole range of them, the UV guidelines, the visible and infrared guidelines, and the laser guidelines. And Directive 2013/35/EU on electromagnetic fields was similarly based on all of the EMF guidelines that we publish. So, again, we have a formal relationship with the European Union. They don't have to use our guidelines, but actually it makes sense from their perspective. If you've got a set of guidelines from a body you have a formal relationship with, why would you go somewhere else? And of course, guidelines may be used directly by employers or anybody else who finds it useful. How do we develop our guidelines? Well, we're looking for what we term scientifically substantiated adverse effects. So basically, something that does harm and that we're confident actually happens. And you may think that's obvious, but one of the big problems we have in some of these areas is actually identifying what does actually happen. To be scientifically substantiated, we think the effect should be observed in more than one study, and we think that those studies should conform to accepted scientific practice and quality criteria. So, for example, for an experimental study, we'd expect them to have adequate dosimetry and to use proper sham exposed groups. For epidemiological studies, we'd expect there to be a proper description of the study population. We'd be looking for well-defined exposure contrast. Epidemiology is a very blunt tool. You have to have a fairly big difference to pick out effects. We expect there to be proper control of confounding factors and proper efforts to minimise bias. Whatever the type of study, it has to be properly analysed with proper statistics. And we would look for results to be consistent with the wider scientific literature. So we looked for some confidence that actually, yeah, this is what we expect to happen by looking at other types of effects. We also look for evidence of a dose-response relationship. It's very difficult to set guidelines if you don't understand the dose-response relationship. So the first question is, well, is the effect adverse? Well, you sort of touched on that, but it could be adverse to humans, could be adverse to the environment. And then we'd be asking, well, is there a threshold to that adverse effect? Is there a point below which it doesn't happen? Because that would be really useful in terms of setting guidelines. If you know there's a point at which you're all right, you can set your guideline below that point and everyone's happy. That isn't always the case, but it's useful. But in any case, we want a dose-response relationship that we can use as a basis for setting a guideline. We also have to recognise uncertainty in the scientific literature. So dose-response relationships are often subject to uncertainty. You get a lot of problems with things like biological variability. So you may get multiple studies in the same species, but you've got some variability. But more difficult may be if you've got data in one species and you're trying to extrapolate that to another. So, for example, we might be looking at lots of animal studies, but actually we want to set guidelines for people. So we need to be able to bridge that gap somehow. That's where epidemiology comes in, if it's available. We also understand that if there's a dosimetric assessment, I've always said we expect there to be one, then that in itself is subject to uncertainty. It could be a measurement uncertainty or a calculation uncertainty. So there are uncertainties everywhere. So just because a study comes up with a number, we recognise that number may not be the ultimate answer. And we need to try and put in place some sort of reduction factor to account for this uncertainty. And it's one of a number of things we could do to account for that. The magnitude of the reduction factor varies, depends on how severe the impact of the effect is, and also on what we think the level of uncertainty is. How confident are we about the numbers that we're looking at? Because we've got all this uncertainty, we've got a problem that actually we might be wrong. And new data might come along and show that we were wrong. And so periodically we might want to look back and say, well, do we need to change things? So we can look at the evidence that's coming along. We do that on an ongoing basis. And when we think there's sufficient new evidence, then we'll form a project group to sit down and start to formulate a revision of the guidelines. And it may be that the consequence of the work of that project group is actually there's no basis for changing anything. So the answer might be that the numbers stay exactly the same. But at least we've gone through the process of justifying where we are. So the project groups that we have ongoing in the commission that's just coming to an end, 24, are listed there. A couple of them are finished at the top there, one on short wavelength light and one on ultrasound. A number of the others are allegedly ongoing, but we have a bit of a problem in that quite a lot of the chairs are retiring. So at the very least, when the new commission meets in July and decides on its work programme going forward, we're going to have to decide what to do with those that are without a chair, whether they continue when we find a new chair, or whether we decide that actually they run their course. And then there may be other things that get brought in. From the perspective of this conference, there's probably a couple that are useful. The one on chronic UV exposure, which is an active project group at the moment, and the one on the relative spectral effectiveness factor, which is currently on hold, but I'm going to talk more about that one because that's the one that you guys are actually really interested in. So in terms of UV guidelines, as I said, they have a long history, and they were last revised in 2004, which is 20 years ago, and that revision actually just reaffirmed previous guidelines. So nothing really changed. There was a bit of clarification, but fundamentally they stayed essentially as they were. However, at that stage there was a recognition that there were continuing uncertainties in relation to things like whether UVA is involved in melanocytic skin cancers, the relative roles of UVA and UVB in cataract development, and things like modulation of the immune system by UV. So there were questions that we didn't have answers to at that stage. Some of those questions are being answered in the chronic UV working group, project group. But there was also something that had really arisen by sort of the whole move towards far UVC, and that's the question about whether the relative spectral effectiveness factor S lambda is appropriate or not. So, to explain this, I probably need to explain that the ICNIRP guidelines, which are based on prevention of acute adverse effects on the eye, they are considered to provide adequate protection to the skin as well, but the basis of the guidelines were thresholds for effects on the eye. And they set a limit on effective radiant exposure of 30 joules per square metre in any 8-hour period. But it's effective radiant exposure, so it's radiant exposure weighted with this S lambda weighting function. So it's the S lambda weighting function that currently sets the limit for use of very short wavelength UVC. There's a second limit on total UVA exposure, which is set at 10 kilojoules per square metre. Clearly, with all of the interest in far UVC, driven largely by the pandemic, but other applications as well, there's now a question about is that value that we're using appropriate or not? So this is the S lambda weighting function. If you plot it out on the log scale, that's what it looks like. And it has to be said that it works, or seems to work, quite well across most of the UVB, UVA, and indeed most of the UVC range. But up until now, there haven't really been many applications that have required us to go right down to the really short wavelengths. So it's not really been tested. If we look at the data that it was based on, as I said, these were acute effects on the cornea and the conjunctiva. And actually, they're based on these data points here, and effectively, these are the inverse of that weighting function that you just saw. So that's where the data came from originally. Now, most of that data is pretty old, dates from the 1970s, but there's data there on effects on human cornea and on primate cornea. That's important to remember. So, I think potential problems with the current S lambda value. We know that there are relatively few threshold data at these very short wavelengths. So that's a limitation. We'd like there to be more. We know that because the studies were done in the 70s, they were struggling to get enough energy into the experiments, and so consequently they had to open the slits on the monochromator. So they had a very broad bandwidth for these short wavelength data points. 10 nanometers full width half maximum. So we can ask the question, is that a problem? A member of the commission has done some modelling on that and reckons it makes a difference of about 20%. So probably not enough on its own to want to change the numbers. But we've also got a potential for out-of-band contributions. A bit harder to quantify that one. So I think the point we're at the moment is it's relatively easy to say that the data underpinning the current values of S lambda are not what we would want for these short wavelength values. Ideally, we would have something better, but in order to think about how we move forward on this, we need to think, well, how unreliable are they? Are they really a problem? And is there anything better? So on the question of is there anything better, the problem is that to date, we have relatively few useful data. Most of the data that's out there relates to skin, not useful to us because the current limits are based on effects on the eye. So we really need better eye data. And one of the real problems we've got is that the eye data we've got at the moment relates to effects on primates and humans. I haven't seen anything on primates and humans. In fact, I suspect that ethically you wouldn't be able to do those experiments on humans today. So that's a problem in itself. There are some other issues that we could identify in some of the more modern work. We know again that some of the early excimer labs had a problem with out-of-band contributions. So again, how reliable is that? And I think some of the experimental designs have been constrained by accepted germicidal interaction. So a lot of people are quite happy to go and stain for CPDs as an endpoint. In reality, we know that CPDs get reversed by short wavelength exposure. So is that a reliable endpoint to be using? So maybe we need to think about a paradigm shift where we don't just take what we know about 254 and try and apply it to short wavelengths. We adopt a different approach and think, well, what are we expecting? How do we approach this? Clearly we need more data, and one useful contribution here is the project led by David Sliney to try and look at, well, what would be useful data and try and encourage people to fund this work and to perform this work. Ultimately, we can't improve on the current values unless we have something that we can base new values on. And that's pretty much the situation where we are at the moment. So ultimately, we're there, we are the accepted authority, but we do like to be rigorous in our assessments. We are restricted in what we can look at, so we don't take into account what applications may or may not be. What we do is to look at the science and to give our best view on where limits should be set, but we need to base those limits on a sound and robust scientific basis. And actually at the moment, it's over to you guys to give us the tools to be able to do that. Any questions?